Welcome to this explainer. Okay, I want you to imagine this scenario. You're just going about your normal day, maybe having a coffee. You feel a sudden tickle in your throat. You cough, and suddenly there's blood. For literally anyone, this is a visceral, deeply terrifying moment. It triggers pure survival panic, right? But in the world of clinical medicine, this dramatic symptom kicks off a fascinating, highly structured investigation. Today, we're going to step into the shoes of a medical detective to decode this alarming symptom and understand exactly how doctors systematically track down the culprit.
So, you just coughed up blood. Now what? As the patient, your first instinct is to assume the absolute worst. The alarm is overwhelming. But for medical professionals, this dramatic inciting incident is absolutely not a time for panic. It's basically the starting gun for a calm, logical, and incredibly focused process. They don't guess, they don't just jump to conclusions. Instead, they rely on a battle-tested clinical framework to gather clues and neutralize the threat.
All right, let's dive right in. The absolute first thing we need to do is establish the exact parameters of the problem we're trying to solve here. The official medical term for coughing up blood is hemoptysis. By strict definition, hemoptysis is the spitting of blood that originated in the lung or the bronchial tubes. And this distinction is absolutely vital. A patient might be spitting blood that actually just came from a severe nosebleed, or maybe blood they vomited up from their stomach. True hemoptysis, though, means the bleeding is happening deep down in the respiratory system. Once we know for sure the blood is actually coming from the lungs, the immediate next step is clinical triage. Doctors have to quickly separate a manageable, maybe chronic issue from an immediate drop-everything life-threatening emergency. They classify this into two main categories: non-massive hemorrhage, which is defined as bleeding less than 200 milliliters a day, versus massive hemorrhage. Crucially, massive hemorrhage isn't just about the sheer volume of blood. It's really about the devastating physiological impact. If the blood is causing an airway obstruction, or if it's causing hemodynamic instability, meaning the patient's blood pressure is just rapidly dropping, well, that is a massive critical emergency that requires instant intervention. Now, you might be wondering how much blood actually pushes a patient into that life-threatening danger zone. The number is startlingly low. Just 150. If a patient expectorates roughly 150 milliliters of blood in a 24-hour period, which to put that into perspective is equivalent to just about half a cup, or if they're bleeding at a rapid rate of over 100 milliliters per hour, this instantly elevates the situation to a life-threatening emergency. Think about that for a second. Just half a cup of blood over an entire day is enough to potentially drown the lungs' delicate air sacs and completely stop the exchange of oxygen. Okay, so once the patient is stabilized and out of immediate danger, the real detective work begins. The list of diseases that can cause bleeding in the lungs is incredibly long and, frankly, pretty intimidating to memorize. To handle this, clinicians rely on the ultimate detective's cheat sheet, the battle camp mnemonic. This mental tool brilliantly chunks a massive list of potential diseases into manageable suspect profiles. It ensures that in the heat of the moment, a doctor doesn't miss a single potential cause. Let's actually break down these battle camp suspects into their logical categories to see what we're up against. We have infectious culprits, which are incredibly common, including things like severe bronchitis or tuberculosis. We have malignant suspects, primarily lung tumors and cancers. Then there are vascular causes, like a pulmonary embolism, where a rogue blood clot strikes the lung tissue. And we even have autoimmune suspects, like Goodpasture syndrome, where the body's own immune system gets confused and literally attacks the lungs. This framework really highlights the incredibly wide variety of culprits that could be responsible for that one single symptom of coughing up blood. So, now that we have our lineup of suspects, how do we actually figure out who did it? Well, we transition to the vital evidence gathering phase. In medicine, the most powerful clues don't always come from a multi-million-dollar MRI machine. They come directly from the patient's story. Cracking these historical clues is the true art of clinical diagnosis. Every timeline, every habit, and every single accompanying symptom a patient describes acts as forensic evidence that points us toward the correct battle camp suspect. And this brilliantly illustrates exactly how this deduction works in practice. Say a patient comes in with hemoptysis, and their story reveals they're a heavy smoker, they've experienced recent unexplained weight loss, and they present with something called clubbing, which is a very specific swelling at the tips of their fingers. When a medical detective sees this, they immediately narrow their focus. This specific, dangerous combination of clues points almost exclusively to a malignant suspect, bronchial carcinoma or lung cancer. But what if the blood looks entirely different? If the patient is producing a pink, frothy sputum, and it's accompanied by sudden, severe dyspnea, which is profound shortness of breath,
Well, the character of the blood completely changes our diagnosis. We aren't looking at cancer anymore. This frothy presentation points straight toward acute pulmonary edema. Basically, this means fluid and blood are backing up into the lungs, very often because the heart is failing to pump effectively. Now, sometimes the clues are a bit more graphic, but they are just as important. If the historical clue is thick, copious, purulent sputum right alongside the bleeding, we have to pay very close attention. It isn't just an unpleasant detail, it's a critical piece of evidence. That purulent or pus-filled quality tells us there's a heavy, destructive infection going on. It points directly to a suppurative lung disease, which could be a pocket of infection, like a lung abscess, or severe damage to the airways, like bronchiectasis. Or consider a patient presenting with a more classic infectious profile. They're coughing up blood, sure, but their history also includes a persistent, low-grade fever, a chronic cough that just won't quit, and notable weight loss. In the context of hemoptysis, this specific trio of clues is a massive red flag. It should immediately elevate tuberculosis to the very top of our suspect list, prompting rapid testing and strict isolation protocols. Let's group these final clues together to see just how wide our diagnostic net must be cast. If the coughing up of blood hits simultaneously with sudden, sharp chest pain and a pleural rub, which is this distinct friction sound a doctor can actually hear through a stethoscope, that points to a pulmonary infarction. This means a section of the lung tissue is actually dying, likely because a clot has blocked its blood supply. On the flip side, if the patient has hemoptysis but also has purpura, purple bruising on their skin, or they're bleeding from their gums or other sites, the lungs might just be a victim of a larger systemic issue. This strongly suggests a generalized hemorrhagic disorder that's affecting the entire body's ability to clot properly. So the really crucial takeaway here is how all of this comes together in just a matter of minutes. When faced with the terrifying sight of a patient coughing up blood, doctors don't freeze. They execute this rapid mental algorithm. Step 1. They assess the volume to determine if it's a massive, life-threatening emergency or non-massive event. Step 2. They recall the battle camp suspects to frame all possible causes. And Step 3. They meticulously map the patient's historical clues directly to a diagnosis. It's a truly brilliant system that turns absolute chaos into a structured, life-saving plan. This whole process brings us to a rather fascinating realization, doesn't it? If a single terrifying symptom like coughing up blood can be mathematically reverse-engineered to unlock dozens of specific, complex medical conditions just by paying attention to the surrounding historical clues, it really makes you wonder. What other hidden clues, what tiny pieces of evidence is your body sending right now that you simply haven't learned how to decode yet? Thank you for joining me for this explainer. Keep learning, keep paying attention to the details, and I'll see you on the next one.